Hi everyone. Good afternoon, and welcome to the webinar. We're going to be starting the webinar very shortly. My name is Justin Wolting. I'm our manager of product development, innovation, and Amplify Care, and I'll be help moderating the session here. Just a couple of housekeeping items to talk about off the top here. This webinar will be recorded. All of the lines are muted. And you are encouraged to be asking questions in the Q&A panel. That's located in the bottom center of the screen. We'll be taking questions throughout the presentation here, throughout the webinar, and we'll be able to address some of those different questions more towards the end. Please feel free to use that Q&A session. But without further ado, we can begin. So really appreciate everybody being able to join the session. The session's title is Navigating Clinical AI, a Practical Approach to Using LLMs in Primary Care. I'm absolutely thrilled to be joined by two leading clinicians in this space, Dr. Naik and Dr. Rajesh Girdhari. Just before getting into introductions there, I just wanted to go over the agenda for the webinar today. We'll do a little bit of welcome and introductions, and then I'll be able to pass it over to our panelists. We'll go through a little introduction to AI just to set the foundation. We'll talk a little bit about some AI risks, the benefits, and the evaluation there. But really the core of this webinar is going to be within the actual demos. So we're hoping from this session that you can take a real practical approach and see some of these different AI solutions, these LLMs solutions in practice. So we'll spend the majority of our time there. And then we encourage you to think of different questions you would like to ask our two panelists, and we will be able to address those in the questions and discussion section towards the end. Mentioned before, but I'd like to welcome again Dr. Naik and Dr. Rajesh Girdhari. Dr. Neil Naik and Dr. Rajesh Girdhari are both clinician champions and leaders within this space. Dr. Neil Naik, as you saw from the first slide there, has lots of different credentials and is a leader in lots of different spaces. Really has a passion for AI, and I think you'll see that come through in the later demos and discussion that we're going to have there. And to Dr. Rajesh Girdhari, also a leader in this space and really a leader across different teams. AI is really sort of really an evolution of a lot of different technology, and Dr. Girdhari has been a leader in this space for many different years, focusing on a lot of different types of different technologies. And really, this is sort of an evolution of that, and really excited to dive a little bit more into the details there. Really, without further ado, so that we can get going, I'm going to pass it over.
Great. Thanks so much, Justin, for the kind intro. And it's nice to be here talking to all of you today and looking forward to our Q&A at the end. Um, as Justin said, my name is Raj Girdhari. I'm a family doctor in Toronto and doing a lot of stuff with digital. I'm just going to walk through a bit of some intro here, and then I'm going to hand it off to my colleague, Neil. I think it's no surprise to many of you who are in the audience, or probably all of you, that working in primary care. I think most of you are working in primary care, but even in specialty care or acute care is places a ton of demands on the healthcare providers, uh, not only from the patient volume, but also just to stay on top of all of the information, clinical guidelines, new studies coming out. A few years ago, a group got together and just looked specifically at guidelines and specifically at primary care, and they sort of wondered to themselves, well, if I actually followed all of the guidance, how much time would that actually take? And so, just as a little bit of a starter here, we're just going to take a quick look at that study, and I'll just get you to go to the next slide, Justin. Yeah, this is their outcome here was looking at the guideline recommended preventive chronic disease and acute care. So they did include some additional care on top of the guideline stuff. preventive care, chronic care, to these patient panel. I think the size they chose is 2,500 for the patient panel. And then they went a step further and said, well, how much time would the clinician actually need to document that and manage any messages related to that? And then, many of you have probably seen this already, but we'll go to the next slide with the big reveal here. And so you need about 26.7 hours a day to take care of that panel of 2,500 patients. And you can see the breakdown that they came up with there. 14 hours a day for preventive care, 7 hours a day on chronic disease management, 2 hours a day for acute care, and then it's kind of a whopping additional 3 hours for documentation and inbox management. And you can imagine that for some people that might actually take more time. And so that's not possible. And so I think they wanted to do that to sort of explain or sort of I think draw up the reality of so the choices that primary care providers have to make on a regular basis. They can't do all this, so they have to focus on certain areas, and they have to reduce in some areas. And so I think if you go to the next slide. You can go back to the slide before. I'll just say that in this particular study, which we can share the link with you. They talked about different approaches to managing this workload, and one of them that they talked about actually was looking at team-based care. And so they looked at like so if you got a team-based approach to this, like you could really cut down on the preventive care and the chronic disease management. And that sort of this study predates AI, and so that was sort of what they were arguing. But I think it is highly relevant, especially when we see some of the new AI tools that have come out for like documentation. There's tools for inbox management as well. That we know AI can also help with this, and the focus of this talk is really around LLMs, large language models, and more like how can they help you stay on top of clinical practice in 2026. So you can go to the next slide, please. I think probably most people have a sense of what AI is. This is just one definition, and it's you can think of it as software that can do things that typically you would take some kind of cognitive input from a human to do. So some kind of decision making, some kind of complicated question, AI can break that down and can give an answer, and that's not always necessarily going to be the right answer or even a real answer or the answer that you're looking for. But it can analyze data, it can make decisions about data, it can recommend next steps based on that data, and I think what separates it from programs in the past, and my colleague Neil will probably not tell you this, but he's board certified in AI and in medicine, and so if you want to take a deeper dive, there are ways to do this. But I think what separates this from other software that we might have seen in the past is the way that the software works is based off of probabilities. It's based off of inferences that are made from looking at millions of different instances of data, or even billions, and that's different from a program where it's like if X then Y. So when we talk about drug-drug interactions, which is one of the things on the slide here, like many of you may have worked with EMRs, or I don't know if anyone remembers like Hippocrates, like older software that could do a drug-drug interaction. That was just looking at a list of interactions that was provided usually by a drug company, and running it like basically cross-referencing those two lists and saying, hey, there's an interaction. AI could take that a step further and, for example, look at some clinical context of the patient, and could even say, like, based on this, I actually don't think that this is like a very particularly important drug-drug interaction for this patient. I don't think it's going to matter. I think you can give it to many ways, which is what a lot of us do when we just click OK, when we get like a yellow drug-drug interaction or something on or like a minor drug-drug interaction in our EMR. And so that's the difference between AI and sort of the software that came before. Um, so a couple other events of things that AI can do here. Look at scheduling patterns. Look at patients. Have they come in the past? Um, what is their show rate? Can we actually predict who's not going to show up? Can we do better at smart scheduling so that we can maximize our use of the team? Um, or do we need to reach out to those patients in order to try to get them to come? Things like that. Other things it can do is it can, as we'll look at a little bit later on today, with the LLMs, they can look at patterns, uh, images, test results, and they can interpret those. So quite a bit more than what was capable of in the past with software. I'll go to the next slide, please. And Neil, thanks for putting that link in the chat. Talked about this already. I think the classic sort of software approach there, and how we've moved to sort of the next level of machine learning, which is basically showing a computer a pattern of trying to teach it basically using different examples and saying that this is in or this is out, um, and then getting it to recognize over time. And I think Neil's going to show you some examples of that in his section of how that can be done. And then deep learning is essentially uh, like the next step beyond that, where uh, different connections can be made between different data sets. And again, I'll defer to my colleague, Dr. Naik, to provide some more insights on that. As you can see from the slide there's sort of a history of AI. Deep learning would sort of be considered to be like the most advanced state of AI. And then if you look at the diagram on the left there, the Venn diagram, there's something else called natural language processing, which is the ability of computers software to interpret human speech and turn that into code that they can use. And then so somewhere in the middle of the deep learning and the natural language processing, we get to this generative AI with products that we're going to show you today. Things like ChatGPT, Claude, interactive kind of AI tools that people can use. So uh, can go to the next slide. So this slide just kind of talks about like there are different competencies that can be considered for using AI. We're not really going to go deep into them today, but I think they'll sort of be around in the ether as we talk. And so one of them is looking at is trying to figure out how to assess risk. And so really the key point here is that at the end of the day, you're still liable for any clinical decisions that you make or any advice that you give when you use AI tools, or when you implement AI tools in your practice. And so these are all important things to think about. And I think a lot of us are familiar with scribes, AI scribes, because they've been around for a couple of years now, and they've been heavily promoted. And I think most people have probably heard that, when you use an AI scribe, really you should always read your notes and correct any errors. And so, if you didn't read your note and correct any errors, like you could imagine that there might be some risk to the patient if there's something wrong in there and the patient reads the note if they have access to it, or if another provider reads the note and they get the wrong information, or if in fact you don't remember what happened and you read the note and you do something wrong based on that. But I think a lot of us might actually say that using AI in this case, because you have a chance to review it right away, is probably lower risk than using AI in other cases where maybe a tool is giving direct advice to a patient who might be interacting with it, looking for some advice around their current symptoms, or trying to make a clinical decision about some other issue. And so that would be sort of a riskier level of AI. And I think, the sort of higher level risk could be things like, AI is just reviewing all your prescription renewal requests and renewing those for you, which, may result in some more direct harm to someone if it makes a mistake, for example. So we have to think about risk when we're using AI, and I'll just go to the next slide. Uh, Important to also understand, AI is still software, and it's not a trained clinician like yourself. It is trained in different ways, but there are important limitations around what AI can do. And number one is that it doesn't really have the same five senses that you and I have, and so if you don't tell it something, then it's not going to be magically able to to sense that out, right? So the input that you give it is all it's going on for the most part, and then whatever it's been trained on. It can't look up and see that someone's in obvious respiratory distress or something. Um, Again, it's not really trained in ethics, like in the same way that you and I might be through our years of training, which means that it might give recommendations that are unethical, and so that's important to keep in mind. I know programmers have tried to put guardrails and things around their tools, but I think you just a quick Google search and you'll see that those don't always work. Again, handling novel situations. I mean, I think that like every situation in some ways is kind of novel for AI, right? Like it doesn't necessarily, depending on the tool that you use, it doesn't necessarily remember the last thing that you talked about. It doesn't, and I think it tries to do the best job that it can with the data set that it's been trained on to give you an answer that you're looking for. But it's it's I guess for that one, it's important to remember that yeah, that basically it may not be the best at applying something it learned from before to a new situation, and so in a way that you and I might be, and then obviously I can't replace clinical judgment. Go to the next slide, please. Talked a little bit about some of the competencies, and so you'll probably hear these throughout the talk. I don't want to we could spend a whole hour talking about these things, but these are some questions that that all of us who are working in primary care or in other fields in healthcare may want to ask about AI tools. There's six here noted. Um, Foundational knowledge. What is the tool? What does it do? Critical appraisal. Is it relevant for this particular clinical scenario? Was it is it approved by some sort of governing body? Does there any evidence that shows that it improves outcomes for this particular clinical scenario? Technical use, which is what we're going to get into today more. How do I use this tool? There's another one there. How do you explain to patients about the tool, answer their questions around privacy, security concerns, and then unintended consequences. I think we can put that link in the chat as well to this article. It is at the bottom of the slide, but I do think that's a really interesting article for anyone who wants to learn more about sort of a higher level theoretical approach thinking about AI competencies. And we can just go to the next slide. I think we can probably just skip this slide because it's pretty similar to the last one. It's just another article thinking about competencies. And then we're going to get into a lot of these examples today, but just to kind of highlight that AI is already used in healthcare, and I think some of the earliest adopters were the radiologists. I think like you can imagine that teaching a computer to read a chest X-ray, for example, might be something that you could do just by showing it a whole bunch of chest X-rays and then telling it, what has pathology and what doesn't have pathology. And I think that specialty in particular has been on this for a number of years. Yeah, and we'll get into some of these other examples later on. So I think next slide, and I think is this where I pass it over to you, Neil? I think.
Yep, happy to take over.
Yep.
Perfect. Thanks so much, Raj. Hey folks, I'm Neil. I'm another AI enthusiast. As Raj alluded to, did some additional courses, both at U of T, McMaster, but also at the American Board of AI in Medicine, a course I highly recommend for anyone who's really interested in getting into this stuff. And so it's really important for us as clinicians to know, where does AI fit? Where does it work in our workflow? As Raj alluded to, like, what is the problem we're trying to solve? How do we even analyze to see, are we going to get our KPIs out of this? Are we going to figure out what our ROIs are? How does this work in our workflow? Are we just jumping into the middle of it saying, I like this AI, I saw my buddy Raj use this, and I want to put this into my practice, but not really understanding what the risks are or where we should be watching out for what it was trained on. And that's what I want to show here in terms of three most important failure modes. There are many failure modes, just to let you know, everything from being hacked to privacy security, but I do want to bring up these three. So next slide. So the first one is called out of distribution generalization. This one's fairly easy to understand. It's if I train my model on knees and only knees, and then I throw a cat into it, well, the AI, as Raj said before, was only trained on knees. So it won't, it might call the cat arthritis. We don't know, but it's what you throw the wrong image into something. The next one's more about performance. If you trained your AI on the best possible chest x-rays you could possibly have, but the person who's uploading the images for analysis after it's been deployed might throw an incorrectly cropped image or it's been rotated the wrong way. It wasn't trained to say, hey, by the way, that's rotated 90 degrees or 120 degrees or whatever it is. And this actually came up in a Google study as well when they trained to check for diabetic retinopathy with these beautiful, pristine images. They deployed it, and I believe it was in India. And what ended up happening was the images that they were getting from the real world weren't as clean or good quality. And as a result, it just wasn't trained on that stuff. And then finally, what we start seeing on the outside selection bias is when somebody, you train your AI on a whole bunch of X-rays, you do think of everything you possibly can, but then you throw it a curveball, right? Somebody with a pacemaker, and it just doesn't know what it is, and it's just or an NG2. You can think of different pieces, and it's out of distribution. It's outside of the training model. All right, next slide. This one, feel free to jump into the chat. This one's actually a bit more interactive. This is called incorrect feature attribution. So this is an AI that was asked to delineate between, is it a wolf or is it a husky? And you can see across the first panel, it predicted wolf and it was a wolf. It predicted husky, it was a husky, et cetera, et cetera. And when we look at that second panel, the second row, it predicted a wolf, it was a wolf. It predicted a husky, was actually a wolf. And then you see the fourth image there, it predicted a wolf and it actually was a husky. And I do want, just for 30 seconds, if you want to throw in the chat, what do you think the AI was looking at? Now, if you've seen this before, please do refrain from answering this question because I think this is a great learning exercise for all of us. But what do you think the AI looked at to try and delineate whether or not this was a wolf or a husky? Anyway, ears, background, the environment, the shape. Perfect. Stance, great. All right. Coloring. So few of you guys got it. It's the background. If there was snow in the background, it predicted a wolf. If there was no snow in the background, it predicted a husky. The challenge is a lot of times we don't have a way of asking AI, how did it come up with its answers? You'll see things in OpenAI and in Gemini and things like that, but it's something called chain of thoughts where you can actually go back and see how it thought. But even then, it's not actually as comprehensive as you think it is. Next slide. And finally, there's something called model drift. There's two versions of this. So one is you used your old data to train your AI and you deploy it, and you check it, and performance is really, really good. Then you go to phase two and deploy it. And the new data is a lot more precise, a lot more advanced. And what ends up happening is your AI just doesn't perform as well. And you're like wondering, well, your performance in phase one was perfect. What's happening now? And the data just wasn't comparable. Or over time, your data changes. You put in a new machine, your blood pressure cuff is better, your ECG monitors capture a little bit more detail. And so as the world changes, as time passes, your AI needs to be recalibrated with new data. So just important things to think about when you think about which AI and what application you're putting it into. Next slide. So this is going to be the fun part. Next slide. We're actually going to try and take a look at large language models, and we're going to go back and forth between myself and Raj and show different demonstrations of questions. So the first one I'm going to give over is to Raj, who's going to demonstrate two AIs and a PFT that he has and how the difference between the two AIs are. While he's getting that set up, I just want you guys to think about, hey, were these models trained on reading a PFT? How do we know how many PFTs they've read in the past? Are they only looking at PFTs that were available on the internet, or do you think they had a back end into a large server, right? So the more data points you have, the better the training can be. All right.
Great. Thanks, Neil. I'm just pulling up the PFT example here. So I've tried a lot of different things out with these LLMs in my clinical practice, and I think that this is an interesting example of where an LLM can sort of help me get an initial understanding of a result, and then can help me think about next steps. So I'm going to demonstrate two LLMs here. One is called Claude, which is made by Anthropic, and the other one is called Copilot, which is from Microsoft and very similar to ChatGPT. And so I will share here my screen. I think everyone can see that now. And so uh, so you can put a prompt in here, and then I will just drag and drop um, this in there. And I don't know if I guess you can't really see it, but what I did is I just drag and dropped, like I just did a screenshot of the PFT. I didn't include any patient identifying information like name and age. I did include the weight and the height, which is why it's there. And now, with the prompt, the tool is just telling me more about the results. So it did include the flow loop. It also includes there's some information about a previous study the patient had in February 2017. And then it gives an impression here. And Yeah, so this is the free version of Claude, I will say. So I haven't paid for so anyone can just have access to this now. I haven't paid for the more advanced version. I'm going to do the same thing with Copilot. So you can see it gives an overall impression. This one did not like the drag and drop, so uh, well, no, I can't find the PFT image. There we go. And so I think everyone can see here what's happening. And like this is sort of a much more lengthy report that we're getting. Again, this is a co-pilot, so it is paid in some way, sometimes through an organizational subscription to Microsoft 365 or a personal subscription, because it is linked in with Microsoft's productivity tools like Word and Excel. It's giving an overall summary here. It's comparing it with a prior study. This is actually interestingly the wrong date. That other study that we saw was actually a couple of years prior. I think it was 2017. Um, and then it gives an interpretation here. And so I'll stop sharing now, but so that for me, like when I get a report back on a PFT, and if I have a question about it, if I drag and drop it into there, I might get some additional insights. And then I can decide from there, do I feel comfortable with talking to the patient about this result now with that? Do I want to, e-consult a respirologist for further advice? Do I want to do a general, referral to respirology? So anyways, just wanted to demonstrate that as one example of a way that you can use an LLM, and also that you're not going to get the same answer from both of them. Although both answers I thought were pretty helpful, and both answers were had some of the same core information. So Neil, I'll pass it over to you if you're ready to do your demo.
Awesome. Thanks so much, Raj. All right. So for the next one, what we're going to do is we're actually going to look at skin rash. And this is an image I found online. So it's possible that the AI was already trained on it. So I have two up here. I have ChatGPT 5.2 and I have Gemini here. So we're going to go ahead and hit enter on both of these guys and see what they analyze here. And I gave it no clinical context in this case, right? Um, and so it's just trying to look at the image and trying to figure it out. So the first one, ChatGPT, found it looks like shingles. It justifies why it looks like shingles, and all the associated symptoms. On the right-hand side here, what we're seeing is, yep, again, they found shingles again. Slightly different in terms of the information that they're providing and how they're differentiating the two, and the information that's being provided to you. And what you'll find with a lot of the newer AIs that are coming out, especially the ones that are combined with our AI scribes, is that the details that they're providing or the backend that they're using is actually connecting back to the APIs of OpenAI, Gemini. They don't actually own their own in a lot of cases. Some do, so most don't. And so it's always important to ask, what are you using the backend? Because that also determines what was it trained on. And what we're going to do is we're going to give each one of them a little bit more clinical context and see if it changes its answers here. Obviously, they both got a shingles. The clinical context here I'm giving them is shingles. And so, it's saying, hey, here's your classic prodrome, what's happening. One's going to the pathophysiology on ChatGPT's side. Gemini went straight into management of this patient and complications to look at. Gemini actually gave dosing in this case, which I'm really surprised it did, given that it might know I'm a physician. But on the ChatGPT equally should know I'm a physician too, given how much I use it. So really interesting stuff. And they give things in terms of differential now on the ChatGPT side, whereas on the Gemini side, it went clear cut as to, hey, this is what you should do. So really interesting to see that difference between the two and how that impacts which one you're going to use, when you should use it, and the challenges that come with AIs. Perfect. So I think just for the sake of time, because we want folks to get back to work on time, I think it's important for us to potentially move forward and go to Q&A. Are you okay with that, Raj?
I'm okay with that. I just didn't know if you wanted to mention OpenEvidence,
Oh,
since we didn't
yes.
demo it. Yeah, so.
Yeah, that's fair. All right, let me share my screen again. And you know what, we should, if you are a physician in Canada, you should have something called a MINC ID. And with the MINC ID, you should have access to something called OpenEvidence. And you can actually ask it medical questions like, hey, what is the treatment plan for H. pylori? And it will actually analyze it. And this one was trained specifically on medical information. And that's the difference between this and other AIs. Now, this one is an American program, and so it does specifically go after the American Academy of Family Physicians. That being said, they are international guidelines in terms of treating this. So I'm a little bit more um, happy to go with this. And then you both give your primary and your secondary treatment in terms of what to do. And we can even they even give a diagram as to what to do. And so I can go ahead and ask a follow-up question saying, does this change or are the guidelines different in Canada? Let's see what it says there. And this stuff, you can actually look at chain of thought. What is it looking at? It's looking at the FDA and CDC. And this is where I get a little bit more like, where did you get your information from? Is it truly Canadian or is it not? And one thing with this is I love where it gives me the references because one of the biggest things with a lot of AIs is they hallucinate them. So I will double check their references and just make sure, yep, is this the right information? Is this not? I asked for Canadian information. That's AFP again. So didn't really understand what I asked for. Here's their first link here. They combine Europe, Canada, and the United States, but they, again, didn't jump right into the Toronto Consensus Guidelines. So every AI has an issue. I highly recommend double checking the work that it does. This is very much a tool that can be brought into our workflow. We can look at how it could be integrated. It could be asked for the really complex patients. I had a patient who asked, hey, I smoked a little bit of marijuana. Can I breastfeed? How long do I have to wait before I could breastfeed again? I have no idea. I was not trained on this. And that's where I actually use OpenAI and I double check the resources that's given me. All right.
Thanks for that, Neil. I think I'll just say again, we said it earlier too, but just I would encourage people to, to try these tools out in their clinical practice. I think you need to be careful with just patient identifying information. So I would never put any of that into one of these tools for privacy reasons. But I think putting in, like I said, de-identified information has been helpful at times for both of us. So just cautioning there about that. So where are we at with Q&A? I think there's one question.
Yeah, I can pop in here if that makes sense. So just before getting into the Q&A, thank you so much for going through the multiple demos and providing all the different context. So much great expertise, I think, on display here, and there is some chat also thanking you both for some of that. In terms of the Q&A, I think there are a couple questions that were asked via the chat that I will just ask and open it up to both you, Raj and Neil. And so the first question that was coming through was, are there initiatives to update primary care best practices that reflect AI tools and team-based care? Are those standards likely to influence billing codes?
I think that's a great question. Oh, sorry. Go ahead, Rush.
No. Why don't you go for it, Neil? I was thinking about this question earlier, but I think you should go for it. Yeah.
Awesome. There definitely is policies and guidances, and what we're probably going to see is our colleges and our legal representatives coming out with a lot of the information. So this is one from the College of Physicians and Surgeons of Ontario on what is AI in the clinical practice look like, and it's not specific towards AI scribes, but AI in general. There are guidelines from the Canadian government in terms of AI, again, in general, and the regulations we need around it. And again, these are guidelines because one, it's a balance between you don't want to stifle innovation, but two, safety, security, privacy are incredibly important. What does that play a role? Most things billing takes time. There's negotiations that are involved in there, and I think it would be way above my pay grade for me to comment on that, unless Raj, you have anything else to add to that.
Well, I was just gonna say, like, I mean, we haven't had like major changes in billing and in some, depending how you look at it in primary care. I mean, I know we have different models for billing, but I think, as far as team-based care goes, like I don't think we've, I would argue that I don't think we've had major changes at all in the way that we bill for team-based care, right? And so it just kind of depends like who's paying the team, if the doctor's paying the team, or if someone else is paying the team. And so I think it's pretty slow. Billing codes change very slowly, and the only time I ever saw them change quickly was during COVID when they made some new codes. And so I think that they will influence billing codes, but I think it's still a long ways off. Kirk, that's my candid opinion. So hopefully that it won't take so long, but my sense it will take a while. I I think Kirk has another question here, Justin. Is that right?
Yep, I can read it out to you.
Yeah.
Second question here. I think it's a really good the theme around sort of patient data and standardization. So that question is around, Kirk says, ensuring that patient data collected in EMRs is consistently recorded and organized so that LLMs can be efficient and effective has been a real hurdle. Do you think that given the emerging benefit of AI, that we can expect to see effective efforts to meaningful standards to the EMR patient data?
That's a loaded question. I love it. Yeah, 100%. We absolutely need to start looking at the standardization of data. Healthcare is known to have one of the most unstandardized, non-standardized sets of data. And that becomes a huge hurdle. And that's, go back to one of Raj's earlier slides about natural language processing and how we can convert that over into standardized, LOINC codes, SNOMED CT, whatever it is important. What we lose, though, is every single time we put a cookie cutter approach onto any of our nodes, we lose the clinical context that comes around it, the patient interaction, the intonations that come with it. And so, how do we reconcile that? I'm not entirely sure at this stage, but we want to make sure that healthcare stays human, right? We're not dealing with robots or androids or humanoids. We're dealing with humans, and so with LLMs, yes, but remember that's 84 to 92% accurate, depending on the information you provide to it, which means it's 8% to 16% inaccurate. And are we okay with that as a society when we get to, individual care? Or are we okay with that when we get to population health management? And in some cases, it could be a yes if it means, hey, we're just going to determine a policy. In some cases, it's no if it's a life or death decision on do we give you a drug?
Um, all right. Next one there, Justin. I'll just jump to it. Is it Kevin's question?
I think this is a great question. Yeah, just
Yeah.
so Kevin's question was, what are you most excited about with regard to what's coming next with AI in primary care?
So maybe I'll go first. And I will say that hopefully very soon we will have tools that can really help with a lot of the what I would consider to be sort of like rote things I do on a regular basis. And just kind of help me package those better. And so like one thing that I do all the time, which I mentioned earlier in a slide, but this is not exactly the same, is renew prescriptions that when I get faxes from pharmacies, and I have an approach, and I always in my mind think like, what is what are they asking for? What is the indication? When was the last time we did any monitoring for this blood pressure medication, diabetes medication, controlled substance, like whatever it is. Do I need to do some more, like so on and so forth. That's a process that takes me anywhere from a few seconds to a few minutes, depending on the complexity of the request, the number of requests. That is something that I think could just be packaged up and shown to me by an AI very easily, right? Like this is a request for Ramipril, like the patient's last blood pressure was this. This is why they're taking it. These are the last time you did any blood tests. Like, do you want to renew this drug? Like, click here for yes. Click here to call the patient in for an appointment or to tell them to do blood tests. Like, it's not the machine making the decision. It's ultimately me, but it's packaging up information so I don't have to go out and collect it, right? And I think that's the kind of thing. And same thing with like, HRM report categorization, for example. Another thing that I do like on a regular basis where it's just like, um, this could be done very, very easily. So those are a couple of examples that come to mind. I'll kick it over to Neil here.
Yeah, I completely agree with you, Raj. On a day-to-day basis, 100%, like I need these workflows to be optimized for me. In a different lens, I'm really excited about digital twins, right? So, as a physician, I've memorized maybe three, four antihypertensive medications, but how do I know that you, for your phenotype or your genotype, that drug is the exact right drug for you? Is there any way of me taking your data and build you a digital version of you to say, hey, you know what, based off the studies, candesartan worked worse than telmisartan. Maybe you should be on telmisartan instead of candesartan. And there's no way for me as a clinician to know that. And so I think there are parameters that humans just never analyzed before. We use randomized control trials to say, oh, this one might be better, this one might not be as good, or they're non-inferior. And what we need to start looking at is the personalization of medicine. And that on that pathway is digital twins is the next beautiful part of AI. And that can be scaled into population health management as well. This is a group that requires this type of intervention for them to quit smoking, get their cancer screening done. This other group, we really actually need a low touch method.
I know we're at time. I think there's one other question in the Q&A from Greg Kalita. And she says, well, how would you ideally like to see AI tools like Claude, Gemini, and Copilot integrated into your workflow? I think that's a really good question. That's a question that's going to be loaded with patient privacy concerns because obviously the more integrated, then the more access to patient health information they have. And so I mean, in a perfect world, it would be super integrated and it would have all the information, so I wouldn't have to retype it. Like Neil showed the example where he just put the rash without any clinical context, and then he added the clinical context and he got so much more out of it, right? And you can imagine that if it had access to all the patient information, that it would just be able to give us better advice. And so, maybe you can imagine that in the future, a patient will be able to click a box if they consent to that. But that would take a very in-depth discussion, I think, around what the privacy risks are to them. So I still think that at this current state, that just me being the arbiter of what goes into those LLMs is probably the safest from my perspective, and also because I'm liable for that privacy breach if it happens. And so I'm okay with this separated systems right now. Neil, I don't know if you have other thoughts on that.
Nope, you read my mind. I threw him in the chat just to save us some time.
Great.
Wonderful. So I appreciate everybody staying a minute or so over here. So just really wanted to thank Dr. Naik and Dr. Girdhari just for the fantastic presentation and the insights around all of this and the leadership there. So there's a few kind of parting questions we just wanted to put forward to everybody here, maybe just to think about a little bit in terms of maybe understand what kind of problem you're trying to solve and maybe building on some of the points that were mentioned today. So thank you again. Please reach out to us if you have any questions about any of this or want to know more about any of these solutions or some of these different considerations. We'd be happy to help. But otherwise, we just hope that you have a great rest of the day and hopefully have learned something about maybe how some of these solutions can be practically implemented within your workflow and some considerations around that. So thank you again, and we hope everybody takes care.
Thanks so much. Have a great day, guys.
Here's Thanks, everyone.